So officially, good morning, everybody. It's a Tuesday, February the 8th, and I want to welcome you to our meeting today. To get started, my name is Tony Berry, and I'm the president of the Hearing Loss Association of America, Mission Viejo chapter. We are one of many chapters throughout the United States that provides support for people with hearing loss. To get started, waiting room. Does anybody have any questions about turning on captions? And are we good? Okay, so a lot of experienced people here. Yay! Okay. Okay, I wanted to tell you a couple of things before we bring on Dr. Doherty. The Hearing Loss Association of America is having an annual convention. It will be live this year after going dark for a couple of years. It's going to be in Florida, and the discount for participation, and I probably need to send you information. It's going to be in June 23 to 25. There's going to be lots of technology. They usually have one room that's just like a toy store. There's going to be over 30 workshops over the course of 3 days. So I would like you to consider attending. I am going to email everybody that's here today about the information about the convention in Florida in June, 3 days. All of the workshops are fully accessible. They have hearing loops, listening devices, and the speakers are always captioned. So, let's see. I wanted to share, oh boy. I don't know if you can see that. HLAA, we do not endorse any products or services. My sharing is paused. Why is that? Resume share. Okay, so I don't know. I'm going to stop sharing. I'm not even sure I'm sharing the right thing. Okay, here's my slides. Okay, we do not endorse any single product or service, and this meeting is intended only to provide information, education, and support. I want to thank Caption Call, who provides captioning telephones for people with hearing loss. They are a sponsor, and they actually pay Joe, who is our captioner today. Joe is captioning from Chicago, so thank you for that. We are a 501c3 tax-exempt chapter, and if you would like to donate, we really could help a lot. You can contact me or just go to the website hlaamv.org and click on the donate button. Here's my name spelled out, my email address, and my phone number. So, okay. That's really important for me to get that out. So I would like to bring on Dr. Doherty. I'm so pleased to have you, Dr. Doherty.
Thank you.
She's the assistant professor of neurology division, uh, USC Caruso Family Department of Otolaryngology-Head and Neck Surgery, Keck Medicine of USC. Wow. How do you put that on an envelope if I was mailing something to you?
Your pronunciation was perfect. I'm impressed.
Oh, wonderful. Okay, well, I was practicing, and when I don't hear very well, I'm not really sure if I'm saying it right, when I'm practicing with myself. But thank you for that. Um, okay.
So should I go ahead and start sharing my
Oh,
screen?
yes. So, yes, Dr. Doherty has some slides. USC, as you all know, is in Los Angeles, so just thought I would point that out, but there you go. And she's going to be talking about ototoxic drugs.
Okay. Thank you, Tony, for inviting me, and thank you all for coming to listen. This is an update on ototoxic drugs that we may encounter in our everyday life. So I'm going to go ahead and play. So what is ototoxicity? Ototoxicity is the damage caused by toxic effects of certain drugs or medications or even chemicals to the hearing and or balance organs in the inner ear. Ototoxicity can be temporary or it can cause permanent damage to the inner ear. And these are a list of the classes of drugs in general that can cause ototoxicity. Aminoglycosides have been known for a long time to cause ototoxicity. Some diuretics also do, anti-malarial drugs, anti-cancer drugs, some analgesics or pain relievers, and some other classes that I'll go over today. The symptoms of ototoxicity usually manifest with either ringing in the ears, which we call tinnitus or tinnitus, and sometimes referred to as noise in the head, crickets, water rushing, a buzzing sound, humming, a high-pitched tone, roaring, sometimes whistling. Those are all forms of tinnitus, and tinnitus is a symptom of damage to the inner ear or hearing loss in most cases. So that's sometimes the first symptom that people will have when they're experiencing ototoxicity. The others are sensory neural hearing loss, which is usually bilateral, but it can be unilateral, and it may be asymmetrical, meaning that one ear may be worse than the other with ototoxic damage. And other things are imbalance or disequilibrium, dizziness, and in some cases, ototoxicity can result in complete deafness. So here's a longer list, kind of grouping the different types of ototoxic drugs. And I'm going to go through these. And the most recent update to this list is some of the treatments used for COVID-19 in the early days of the pandemic, and even some of the antivirals that are being used now. So this is a slide showing, it's a cartoon basically of the inner ear, the hearing organ, and it's a cross section of the hearing organ, which is called the cochlea. This organ is where the sound information is transferred to a fluid wave and stimulates the auditory hair cells. And so on the right here, I have a drawing of an auditory hair cell. We call them hair cells because under an electron microscope, it looks like they have little hairs on them. They're actually cilia, and these are extremely important for hearing. So the way that ototoxic drugs can get into the inner ear, and this is all filled with fluid. There's specialized fluid in the in the scala media or endolymphatic duct. And the perilymph is a different kind of specialized fluid that's more like cerebrospinal fluid that bathes your brain and spinal cord. And the fluid in this middle space is really highly regulated. It is called endolymph, and it is very high in potassium and low in sodium. And so the way that the toxic drugs can enter this space is through diffusion through the Reisner's membrane, through the basilar membrane here, and actually getting directly, into the supporting cells and then the auditory hair cells, which are here. So we have 3 rows of outer hair cells and 1 row of inner hair cells, and those are critical for hearing. Another way is through the bloodstream, and then ending up into the cochlea through the lateral wall where the stria vascularis actively pumps ions into the endolymph to keep its potential. So this is what it looks like. This is basically an electron micrograph of the basilar membrane holding the 1 row of inner hair cells and the 3 rows of outer hair cells in a normal hearing ear. And this is a damaged ear. They basically all disappear with certain types of ototoxicity. Some types of ototoxicity don't cause hair cell damage directly, but they can lead to hair cell damage because of damage of the pump, the stria vascularis. So the first class of drugs that we're going to discuss are the ototoxic antibiotics. And as I mentioned at the beginning, the aminoglycoside class of antibiotics have been known for a long time to be ototoxic, and their potential to cause permanent ototoxicity when they enter the inner ear is high. It's irreversible. Some carry a higher risk of hearing loss, and others carry a higher risk of balance disorders because of their effect on the balance organ that is connected to the hearing organ in the inner ear, which is called the vestibular organ. Some ototoxic drugs can affect both hearing and balance. So of the aminoglycosides, neomycin is known to be the most toxic to the cochlea or the hearing organ of all of this class of drugs. And neomycin is a common medication that's contained in, for example, neosporin and polysporin antibiotic ointments, but obviously that's not supposed to get into your ear. However, there are some ear drops that contain neomycin, and they should not be used on people with a hole in their eardrum because they can enter the inner ear and cause permanent damage. And gentamicin, this is a drug that's given intravenously for certain types of infections where the bacteria is resistant to anything that's not intravenous. And so it's life-saving in certain cases. And the same goes for kanamycin and amikacin. Tobramycin, we can use that as an eardrop. It has less ototoxicity than the others, but these 3 are mostly toxic to the cochlea, whereas gentamicin is more toxic to the balance organ or the vestibular organ than to the hearing organ. So gentamicin is something that we'll use in the clinic occasionally to treat Meniere's disease, to eradicate vertigo by basically killing the vestibular cells in one ear. It can't be used in both ears to stop recurrent vertigo in that particular disease because it has a lower toxicity to the hearing organ. And streptomycin was the one initially used to treat Meniere's, and it has a very high vestibular toxicity, but also has some ototoxicity or cochlear toxicity. The other class of antibiotics that's important to be aware of are the macrolides. And these are erythromycin, azithromycin, clarithromycin are examples. They cause inner hair cell damage more than the outer hair cells. And it turns out that the high frequencies aren't as affected as the low frequencies when we look at hearing tests from people who've had ototoxic effects from this class of antibiotics. It's related to the dose that's given. So the higher the dose, the worse the damage. And it is often reversible. Most of the time it is reversible. So when they stop the medication, it will, reverse the situation. The ear will recover. The onset of symptoms of ototoxicity can occur within 3 days of starting the medication. And the first report of ototoxicity from macrolides was in 1973, where erythromycin was given and caused ototoxicity. And since then, azithromycin was first reported in 1994 to show ototoxic effects. Azithromycin is commonly prescribed everywhere. It's basically your Z-Pak you may have heard of before. So it's usually a very short course of antibiotics. And like I said, most often reversible, but, just be aware that any onset of tinnitus is a sign that you might be getting some ototoxicity. And then the clarithromycin and erythromycin can also cause cardiotoxicity or damage to the heart, in addition to ototoxicity. Then we have vancomycin. This is one that's given intravenously, used to treat severe life-threatening infections, including resistant Staph aureus, called MRSA. Many of you may have heard of MRSA. It's a bad bug and it kills people, but most of the time it's sensitive to vancomycin. So they have to, get that through the veins. And the ototoxicity begins with tinnitus, and usually it's only when the vancomycin is used in combination with other ototoxic medications or at a high dose. And so when a patient is on this drug, they always measure their trough and their peak, meaning the peak blood levels of the antibiotic, and the trough is the lowest blood levels before the next dose. And so measuring those helps to reduce the risk of ototoxicity. And as with this drug and all the ototoxic drugs, any incidence of liver or kidney failure will increase the risk of ototoxicity, because your liver and kidney are how you get rid of toxic medications from the body. So if there's some damage to either of those organs, you can have a toxic buildup in the body. So close monitoring of serum concentrations is important. Next class we're going to go over is the diuretics. So many people are prescribed diuretics for various reasons, sometimes for blood pressure, sometimes for swelling in the lower extremities. The loop diuretics, we call them loop because they affect the loop of Henle in the kidneys, and they're a family of water pills that can potentially cause some temporary or even permanent ototoxicity. They're also used for chronic heart failure and kidney insufficiency. So the onset of the ototoxicity from the loop diuretics usually begins with tinnitus, as with many of the other ototoxic drugs. And this may be relieved by stopping the medication. The toxic effect is not on the auditory hair cells with the loop diuretics. It's actually on the stria vascularis in the hearing organ. It's on the lateral wall of the cochlea. When I showed that picture, it's the pump that pumps the ions into the endolymph. And so altering that, the function of that organ can alter the ionic gradient in the endolymph and affect the endolymphatic potential, which is critical for the auditory hair cells to function. And what we see histologically is edema and cystic degeneration of the stria vascularis. So loop diuretics, some of the common ones are furosemide, also called Lasix, that's commonly prescribed. So this is a list of them. Ethacrynic acid isn't often prescribed for humans. It's more used in the lab. It has a higher risk of ototoxicity, and it's reserved for patients with sulfa allergy. Bumetanide has a lower risk than Lasix. So that can be used as an alternative if someone, is having good results from the Lasix, but they start to develop tinnitus. And it's estimated that 6 to 7% of patients taking these medications may be affected. These are other, the rest of the talk is going to focus on sort of other ototoxic agents and other classes of ototoxic drugs. So we have the chemotherapies. Some of them are cytotoxic and ototoxic. They obviously are cytotoxic because the goal of chemotherapy is to kill the cancer cells. So they kill the cells that are rapidly proliferating or making multiple copies of themselves. These are the platinum-based chemotherapies that are known to be ototoxic. Examples are cisplatin and carboplatin. They affect the outer auditory hair cells, the stria vascularis, and the spiral ganglion neurons, which is the nerve that carries the sound information to the brain. Oxaliplatin is less ototoxic due to the fact that it's not readily taken up by the auditory hair cells. And vincristine is another chemotherapy drug. It's in a different class of chemotherapies, but it's known to cause neuropathy and has been reported to cause low frequency sensory neural hearing loss that is irreversible. And all the ototoxic effects of chemotherapy are generally irreversible. It's been shown that approximately 61% of patients taking these chemotherapy drugs are affected, and monitoring protocols are recommended, meaning that once the oncologist decides to prescribe one of these drugs, then the patient should get a baseline hearing test and should be followed by the audiologist at least every 3 months. And now we're going to go to a different medication. These are the NSAIDs. It stands for non-steroidal anti-inflammatory drugs. Aspirin is very commonly used, and it has some ototoxicity that is reversible at high doses. So the low dose that we take 81 milligrams a day is not going to cause ototoxicity, but if patients are taking it several times a day or taking more than the recommended amount, then it can cause ototoxicity, but it's generally reversible. So it usually presents with tinnitus. And then if the aspirin is stopped, then it will go away in most cases. Now, acetaminophen, which is largely known as Tylenol, causes some irreversible ototoxicity and can lead to severe to profound sensory neural hearing loss when taken at very high doses repeatedly or chronically. And that is in the situation usually when it's combined with an opiate, so that the patient is taking, like, for example, Vicodin or Norco, which is an opioid compounded with the acetaminophen, and they get addicted to it. We have, an opioid epidemic in the US at this point, and they are taking large amounts of those pills on a daily basis and over a long period of time. And sometimes this results in a rapid onset of sensory neural hearing loss, usually affecting both ears, and it's rapidly progressive over a couple of weeks. It also can cause liver toxicity. The acetaminophen is known to be toxic to the liver, whereas the opiates are the more toxic part of the medication, but there's some synergism between the opiate and the acetaminophen together to cause worse ototoxicity. So, as I mentioned, sudden leads to deafness within weeks if the opiates are not stopped. And these are people that are taking more than 20 to 30 pills a day. Normal prescription amounts are limited to like 6 pills maximum a day. And then the combinations are worse. And the effects are irreversible. They're not responsive to any of the medications that we give to treat sudden sensory neural hearing loss, like steroids. And sometimes these patients require cochlear implantation. So another class is the antiparasitics. We have quinine and ivermectin. Also, I list that at the end because it's been used recently to treat COVID. So quinine and quinine-containing aspirin can cause a reversible tinnitus and sensory neural hearing loss. Tinnitus is usually the first symptom, as with most of the ototoxicities, but the patients can also present with balance issues. And quinine is also prescribed for restless leg syndrome. Besides being an anti-malarial drug, it's contained in tonic water. There's a small amount of quinine in tonic water, as in these other medications that I listed here that can be over the counter. And so, watch your intake of those gin and tonics. But I think it would take far more gin and tonics than anyone could drink in a day to cause ototoxicity. So, okay. So then I wanted to mention some of the recent treatments for COVID-19. So in the early days of the pandemic, chloroquine and hydrochloroquine were used to treat patients with COVID in the hospital. Since then, some larger studies have shown that there's really no benefit of chloroquine or hydrochloroquine to treat COVID, over other treatments, standard medical management. The ototoxicity that they cause is sometimes reversible. And by the way, the chloroquine and hydrochloroquine also used to be used to treat parasitic diseases like malaria. So that they've been around for a long time. And we've known, for a long time that they are ototoxic, but it's can be reversible if the drug is stopped. And then azithromycin was used in combination sometimes with the chloroquine, and that causes a reversible ototoxicity. And then the treatments like the antivirals, so we have Lopivinar and Rotonavir, and these are basically, they're two different drugs put together. The Lopivinar is the antiviral, and the Rotonavir makes it stay around longer in your body because it inhibits the liver from breaking it down and ridding that drug from your body. So it's just to have it stay around longer. But the toxicity, the good news is it's reversible. Interferon is used to treat COVID sometimes, and it's also reversible. Ribavirin, and that's, I think, the one we've heard about on the news. This is sometimes reversible, but sometimes it's caused permanent damage to the inner ear. And then most of these are presenting with tinnitus and hearing loss, but ivermectin actually results in damage to the balance organ. So it causes dizziness and imbalance, and it is reversible. Okay, and then some other classes. We have the anti-epileptics. So Dilantin has, at very high doses, been shown to cause bilateral vestibular loss in patients. And these other anti-epileptic drugs, like anti-seizure drugs, they are used, I mean, at their normal therapeutic dose, they can cause ototoxicity. So valproic acid or valproate, lamotrigine, and gabapentin, which is kind of it's so like a reverse of what you would naturally think, because gabapentin actually has been used in some studies to treat tinnitus, but it can result in tinnitus. Hyperacusis, sensory neural hearing loss. Hyperacusis is when you're very sensitive to sound, and so sounds at a normal conversational level are bothersome to you. So it's like a sound sensitivity syndrome. Dizziness, ataxia, imbalance can result. Ataxia is like an extreme imbalance, like a drunk person walks. Nystagmus is a reflexive movement of the eyes that happens when there's damage to the inner ear balance organ. And then I just mentioned these other things, which are findings when we do vestibular testing. We can see that there are abnormalities in the saccadic and pursuit testing and auditory nerve testing when we do like an auditory brainstem response test, which tests the integrity of the nerve carrying the sound message all the way up to the brain. There are measurable abnormalities on ABR and nystagmograms with these drugs. These are some environmental agents that can cause ototoxicity: toluene, mercury, lead, carbon monoxide, styrene, manganese, xylene. So, you know, there's lots of things in the environment that we know about that can cause ototoxicity. It's good to be aware of what's out there that might damage your inner ear. And then finally, noise exposure is toxic to the inner ear. Noise levels above 85 decibels sound level for a prolonged time can cause sensory neural hearing loss, and it's chronic and usually irreversible. It depends heavily on the exposure time and the loudness levels. So this is why OSHA set up standards for workplace noise level protection. If the noise level is above 85 decibels, the workers should be wearing earplugs. And so that now exists, but you know, years ago, we didn't know how damaging noise was. And so people working in very, very loud environments with machinery, you know, didn't have any earplugs, and they suffered a lot of noise damage to the inner ear. And the louder the sound, the shorter time it will take to cause damage to the inner ear. So for example, a gunshot or a firework, those can be from 140 decibels all the way up to 210 decibels in a single shot. So that can damage the inner ear. Sometimes the ear will recover spontaneously, but sometimes it doesn't. And so, you know, so I guess you would say it's occasionally reversible in those situations, but I've seen a number of patients where it was a permanent loss. And then concerts, like rock concerts, for example, can be up to 140 decibels, and they last for 3 to 4 hours. So that's quite damaging if you don't wear earplugs. Noise-induced sensory neural hearing loss damages the hair cells, the neurites in the inner ear, which are the nerve endings that communicate with the hair cells, and also the spiral ganglion neurons, which are the nerve bodies and nerves that carry the sound information to the brain. So who is at risk for ototoxicity? Patients with cystic fibrosis, which is a genetic disorder affecting mostly the lungs and the sinuses, with a decreased ability to clear their mucus, and they are susceptible to infections. And so they often end up getting treated with some ototoxic antibiotics during their lifetime because of the severity of the infection. And so they need frequent and recurrent dosages of aminoglycoside antibiotics, for example, that are ototoxic, and up to 40% of cystic fibrosis patients are affected. There's also, sometimes they'll put the antibiotic into a sinus rinse, and that can also cause ototoxicity because of its close relationship to the ears. The genetics do play a role in aminoglycoside ototoxicity. There is a mutation in a mitochondrial RNA gene that, RNR gene that is known to be the underlying cause of severe ototoxicity in patients that receive gentamicin. So, somebody studied why are some patients that are getting gentamicin getting ototoxicity and others aren't, and they found that there was a gene mutation and it affects an estimated 0.2 of the population. So it's not very common, but when the drugs are commonly used, then people can get affected. Cancer patients are at risk because they may receive platinum-based chemotherapies or vincristine. And these are also linked to genetic mutations that the patients may have, which are listed here. I'm not going to go through all of those. And then opioid addicts, like we went over, people with kidney problems, kidney failure or insufficiency, and dehydration. So the state of dehydration can cause the ototoxic drugs to be at a higher concentration and cause more ototoxicity. My slide is not advancing for some reason. Actually, my computer is not responding at all. Okay, I guess that was weird. So how can we prevent ototoxicity? I mentioned the monitoring programs, getting a baseline audiogram for people that are starting a toxic agent that, they usually use these in situations where there's not an alternative. So we just get a baseline audiogram, get otoacoustic emissions, which is a test of the outer hair cell function that an audiologist can do, and then monitoring their serum drug levels and their hearing throughout the course of therapy. Some studies are ongoing and have to investigate whether pre-medicating patients that are receiving these chemotherapies and ototoxic drugs could prevent the ototoxicity. So there's some clinical trials involving aspirin and acetylcysteine, which is basically like an antioxidant, alpha lipoic acid, which is another kind of antioxidant, sodium thiosulfate, which is a toxic in and of its own right, but it can maybe prevent ototoxicity, and then ginkgo biloba. Also, steroid injections into the ear just prior to toxic exposures may help. So this can be done with noise exposure, and there's some evidence to suggest that steroid injections into the ear could prevent hearing loss from noise exposure. There is a trial for a injection through the tympanic membrane of an aminoglycoside blocker in order to prevent the ototoxicity of a patient receiving aminoglycosides when they have to receive it. So you could potentially give them that drug prior to receiving the medication. So that's in a clinical trial. And then this other medication that I put here is an immunosuppressant, and they're studying this for cystic fibrosis to prevent the ototoxicity of aminoglycosides. And it's basically an oral daily pill, and it's under clinical trial also, Epsilon. So how can we treat ototoxicity when it's permanent? hearing amplification. Often patients are still candidates for hearing aids. If they're not, in the case of opioid abuse and deafness due to opioids, they're usually not candidates for hearing amplification. So in that case, we have to do a cochlear implantation. And I just showed a little cartoon drawing of what that looks like over here. There's a piece that goes into the head that gets implanted. It lies over the skull, and then these electrodes are fed into the hearing organ, to the cochlea. And then you wear that outer piece that is the sound processor, and it takes the sound and converts it to an electrical signal. And then it's stimulates the hearing nerve directly, bypassing the cochlear organ. And there is also a vestibular implant being investigated for patients with loss of vestibular function. And you would only do that really if they have complete loss on both sides. And then there are some other trials there was a clinical trial on gene transfer, but it was actually stopped. There's an ongoing trial which is run by Frequency Therapeutics to restore auditory sensory hair cells. And the gene transfer was aimed at that. It just didn't quite pan out. And so I know that there will be more of those studies coming up in the future, but I'm just going to briefly talk about the frequency trial. So this is a small molecule combination that is injected through the eardrum, and it diffuses into the inner ear, and it has been shown, at least in vitro, which means like in a petri dish, and in vivo, which means in the animal, to lead to progenitor cell proliferation. And that's the support cells that surround the auditory hair cells. So it makes them make copies of themselves, and then it leads to differentiation of those cells into auditory hair cells, those cells that we really need for hearing. And currently it's in a phase 2 placebo-controlled, meaning that there's an arm that gets a placebo, and then there's an arm of the study that gets the active drug. It's double-blinded, meaning neither the patient nor the physician injecting it knows whether they're getting the active or the placebo drug. It's randomized, so patients entering the trial are randomized into either arm. They don't know whether they're getting placebo or the real active drug. And it's prospective, meaning it's going forward, collecting data from the point of starting the trial. It's a single dose, so one single injection, and it's a multi-center trial. There are 15 states recruiting patients, including here in Fresno, California is the closest site. The goal is to enroll 124 patients between the ages of 18 and 65. And their primary outcome measure is speech perception, which is, in simple terms, the word understanding. And that's the most important part of speech, is to understand the words. So they're looking at that as the primary outcome measure, and then looking at pure tones and tinnitus and vestibular function. So this is my summary slide. So early signs of ototoxicity include tinnitus, noticing maybe some hearing difficulty or difficulty understanding, dizziness or imbalance. Monitoring is key, getting those audiograms before starting any ototoxic medication, getting some baseline vestibular testing, and then stopping the offending medication, and rehabilitation options, which I kind of went over. And thank you for your attention today. Does anyone have any questions for me?
And I'd like to ask if people could use the raise hand feature. In the toolbar, there is reactions. If you click on there, and then just click raise hand. I know there was a lot of information, wonderful information. And so I had a list of medications that I'm taking so that I could, You see if that kind of, you talked about that. Okay,
We got
Stephanie.
2 raised hands.
Yeah.
Yeah. Hi.
Stephanie?
Can you hear me okay?
Yes.
Okay, all right. Thank you. First of all, thank you so much for the pacing and enunciation of your presentation. As a
Yeah.
profoundly deaf person, sensory neural hearing loss with 1 cochlear implant, I can struggle with Zoom presentations, and even without captioning facilitating that dynamic for me, I could understand what you said. So kudos to you there. I think the moderator may have already said that she has a list of the locations that are recruiting for the test that you mentioned, and that is specifically what I was interested in. So if that's something that can be distributed, I would like to receive that, please.
I can email you, Tony. I can email you the all the information on that.
That would be wonderful. And when I send out an email about the recording, I can include the list. Yeah.
Great.
Okay. Thank you, Stephanie.
Thank you.
So we've got Jim Rao. Want to unmute yourself?
There we go. Can you hear me now?
Yes.
Hi.
Okay. First of all, I want to compliment the captioner. That was an amazing job of getting all the medical stuff transcribed so we could read it. My question is, what effect does a pre-existing condition, especially central neural hearing loss, have on the likelihood or the progression of ototoxicity with the drugs that you covered?
That is a great question. I would say, so we know that existing conditions such as hypertension and diabetes and hypercholesterolemia, meaning, high cholesterol or high lipid counts, those conditions are already associated with a higher risk of hearing loss. Epidemiologically, like it's been studied in large groups of patients. So we know that that's already a risk of hearing loss because of possibly, lack of good blood flow and oxygen to the inner ear. So you have a really good point that the drugs could potentiate that already underlying risk. It hasn't really been studied, but I am sure that's something that should be studied.
Okay.
I hope that
Marilyn
answers your
Rose,
question.
unmute yourself.
Hello.
Marilyn?
Hello.
Oh, yes. I would like to know, but what is vestibular? I don't understand that term.
Vestibular is the balance organ. So it's something, the vestibular organ is the balance organ. That's what it's called. That's like the medical term for it.
Okay, that's what I have.
Hello.
Thank you.
Sure.
And Alan Kitsura, unmute yourself.
Hi.
Hello.
So this is about, I guess, the Dr. Bauman. I know he's presented to some HLA chapters, and he has a book on ototoxic drugs exposed. And in it, he says he has a list of more than 1,000 drugs, herbals, and chemicals that can cause ototoxicity.
I haven't personally read his book, but I will.
It's been out for a long time, so.
Yeah, he's working on a new edition.
He's Dr. Doherty. He's on the East Coast.
Okay.
Pennsylvania, I think. Yeah. And he's pretty well known for the Hearing Loss Association members.
Mm-hmm.
Because he's given a lot of workshops at the conventions, and so. Okay, Jim, did you have another question? Jim Rowe?
No, I lowered my hand.
Okay. So we have a Robert.
Yes, my question is involving tinnitus. I have tinnitus, and basically it was brought on, well, too many rock concerts, my time in the Army, and eventually a shotgun blast next to my head that I didn't know was going to happen. And my tinnitus started in full after the shotgun blast. So having said that, I noticed medications that would bring on tinnitus. Are there any medications or anything that I could do to improve my condition? Diet, medications, anything like that?
There isn't any known medication to cure tinnitus, but I sometimes use amitriptyline. It's also called Elavil. It's a older antidepressant that we use at a low dose to treat tinnitus. I have people take it at bedtime at a very low dose, so lower than like the doses used to treat depression. And sometimes that helps people be, relieved of the annoyance of their tinnitus. It doesn't make it go away. There's really nothing that we can do to make it completely go away.
Well, I've been very fortunate. 95% of the time, I don't even pay attention to it. But the other 5%, like right now, because we're talking about it, now I'm hearing the high-pitched whining. But otherwise, normally I'm busy and I don't even think about it. So I'm very fortunate that way.
Yeah, you are fortunate. And I would recommend you to keep doing that, because if you give it your attention and get annoyed by it, then that starts to create brain pathways, with the centers for emotion and for memory, and then it becomes more of a problem. It's like a vicious cycle.
Right. I'd like to ask a question.
Sure.
So I'm not really sure Dimetapp, which has been around for forever. So I was taking a lot of that when I was in my teens for allergies. It was recommended by the doctor.
Okay.
I'm thinking now that's when I developed tinnitus, and then eventually hearing loss. And now I'm profound after all these years. So what classification does Dimetapp come in, and what do you know?
Dimetapp, I don't think it's on the market anymore, but I used to take that when I was little too. It's I think it's a decongestant and an antihistamine. I don't have any information on it being ototoxic though. It's an antihistamine, bromophenipramine, and then a decongestant. The only thing about decongestants, the like Sudafed and that type of decongestant, they do cause vasoconstriction, and they can exacerbate hypertension or high blood pressure. So, in maybe a roundabout way, it could cause some inner ear damage, but I'm not aware of any reports of that.
Occasionally I take Zyrtec.
Zyrtec is not ototoxic.
Oh, that's good. I try really hard not to take any medication that I don't need. Okay, Judy, you can unmute yourself and ask
Hi.
your question.
I started taking years ago a sumatriptan, which is for migraines, and I really wonder that it contributed to my hearing loss because it's a vasoconstrictor.
How often have you been taking it?
I was taking it maybe at the worst, like a third, like 10 days out of the month. like anywhere from 3 to 10 days for a number of years.
I'm not aware of it causing ototoxicity, but I'm looking it up. No articles on that.
Right.
But yeah, I mean, like you said, it's a vasoconstrictor. So in that way, it could also kind of roundabout cause hearing loss.
By sort of like the hair cells aren't getting enough oxygen.
Yes.
Because the little capillaries are constricted. That's what
Right.
I'm thinking. Yeah.
Right.
Okay. Thanks.
Thank you. Really insightful questions. Thank you, everyone.
Stephanie, you want to unmute yourself?
I wanted to just put in a plug for us, and maybe we're all in this space, but some of our friends may not be, that we need to be our own best advocates. And that, to me, that means, and I've done this actually myself in the past, when prescribed a drug by a doctor, ask the question, is it ototoxic? I've had a doctor actually pull out a guide and research the drug in my presence before completing the prescription. I'm not saying this to bash the medical community. I'm simply saying it as the reality as I perceive it, that across the board, people who don't live in this space in medicine are not necessarily thinking about that. Some may genuinely not have been exposed to the idea of ototoxicity with regard to drugs. Regardless of the case, we're always best served if we ask the question. And so if we all know that, just consider this me putting it out there so that we can then spread that word among our friends and family, because it does no good to be prescribed a drug, take a drug, find out after the fact that there was an alternate drug that might have been efficacious for that condition that wasn't ototoxic. The damage is done, as we've learned from this presentation, whether it's temporary or permanent damage. So the first step is to make sure you're aware, am I taking an ototoxic drug? If it's life or death, and it can be in a hospital, and your life is more important than your hearing unquestionably, then that's not a conversation. But absent that kind of emergency scenario, you have the conversation. We can all still choose the drug that does the damage, but if we do so, we do it knowingly and with the precautions and the prevention and the testing measures up front that this doctor has advised us are in our best interest. So that's just kind of my plea for get the word out for those that don't live in this space like we do. That's all.
Thank you. I think that's a great recommendation. Very eloquently stated.
So I think what's really important is for people that have concerns about hearing loss, family, friends, or yourself, to attend meetings like this, because a lot of people don't even know that there are ototoxic drugs. So they don't know to ask that question. So, attending meetings like this, support group meetings, getting new information, it's part of taking care of yourself. And so, because I didn't know about ototoxic drugs for many years. And I think, Dr. Doherty, I think I was first exposed to that. Well, actually, Neil Bauman, with his book, introduced that idea, but I don't think I really got the real information until I heard you speak about 5-6 years ago, Dr. Doherty. So thank you very much.
If I can jump in here for 1 second, Selma has had a burning question for a while, and she's being very polite, but she really wants to ask a question. Sorry.
Oh, okay.
You have
Selma,
to unmute though, Selma.
ahead. Unmute yourself.
Okay, can I speak now?
Yes.
Yes.
Xarelto and vitamins. Xarelto and vitamins.
Is it ototoxic? Is that what you're asking?
Yeah.
Well, vitamins generally are not, but I guess in Dr. Bauman's book, I was enlightened to hear that some supplements, some herbal remedies are ototoxic, in fact. So let me look up Xarelto.
Did you just look up his book?
Yeah, but I can't read it right now. I'm not a speed reader. I don't think Xarelto has any ototoxic effects.
Can I also ask, how can we send this to our doctor sons and everybody that we know? How can we do this? How can we send your picture, your whole program?
So Tony has she has all the slides, and then I'm gonna send her the information about that clinical trial, and she can distribute it to everyone. Would that be okay, Tony?
Happy to do that. Yes.
Thank you, Robert.
Well, that's why it's important to try to use the reactions, the raise hand. But I understand you're sort of new at this, Selma. So
I have a question.
Advocated for
I'm
you.
sorry. Yes, I couldn't. Can I ask one more question?
Okay, go ahead, Rena.
Yeah. What about amlodipine? Is it ototoxic? It's for high blood pressure. Amlodipine.
I don't think that one is, but let me check. I'm looking on PubMed. See if there's any literature on it.
It's like Norvasc. The brand name is Norvasc.
It's not ototoxic.
No? Oh, okay. I was taking it for many years. I just was wondering. Yeah, thank you. Thank you very much.
Yeah, thank you. Thanks, everyone.
Yeah, let me ask a question that maybe everybody can benefit from. Would it be a good idea if somebody would take their list of medications and visit their pharmacist and ask them, first of all, some medications don't interact very well with other medications. So you may get one from a neurologist and one from a cardiologist, and they don't know what else you're taking, or they're not looking. So would a pharmacist be a good place to go to have an evaluation of all the medications you're taking and a look to see if anything's ototoxic?
Yes, a pharmacist would be ideal to do that, and also to look at interactions between any of the medications you're on.
Excellent. Good. All right. Have we reached the end of our questions? I don't see anybody waving their hand.
Rick has a question.
Okay.
But he has to unmute.
Oh, Rick, you have to unmute yourself. Lower left-hand corner, there's a picture of a microphone with a line through it. You need to click that.
I think he's
Can you hear me?
Yes.
Yes.
How long does it take on the average for a person taking aspirin to be impacted? And secondly, how long does it take to return to the original?
Aspirin is only if you're taking it at very high doses, and I don't know the time frame, but I would assume like maybe a week or 2 weeks of taking it, you would start to develop tinnitus. So it would be new onset tinnitus. And then stopping it just has to get eradicated from your body. So just, the kidney and liver, get that toxin out of your body. And I would think it depends on the half-life of aspirin, is probably about 6 hours. Let me see. Do you take a lot of aspirin, Rick?
No, just occasionally for back condition I have.
Is taking a baby aspirin every day a concern?
No.
Okay, that's good to know.
Yeah.
Thank you very much.
You're welcome.
How much can you take? Oh, here's a question from Jan. Go ahead, Jan. Ask your question.
Yes, can you hear me?
Yes.
Okay. My husband is a Parkinson's patient. He is on many drugs, but probably the two that concern me the most are carbidopa, levodopa, and the what do you call it when you have anti-seizures, which is, I'm not sure which one he's on, but I know he's on an anti-seizure medication.
Yeah, so some of the seizure drugs, like the ones that I listed, can cause ototoxicity. So, monitoring is important, but hearing loss is also associated with Parkinson's disease. So he could get hearing loss just from the disease itself.
Okay, and what about the carbidopa, levodopa?
I'm looking that up, and I don't see anything on it.
That's the main Parkinson's medication.
Yeah. No, it actually was studied, and they studied 6,833 people taking carbidopa and or levodopa, and they found no ototoxicity.
Oh, good. Okay. So then the one we would be concerned about would be the anti-seizure medication.
Mm-hmm.
Yeah, because since he's been on that, I've noticed some changes in him. Balance, or well, he's got bad balance anyway. That has to do with the Parkinson's, but it's more pronounced now.
Mm-hmm.
Seems to have more dizzy spells. He seems to, kind of list to one side instead of the other. So I'm just wondering if all
really?
these have anything to do with the medications he's on. He's on so many medications. It's like over 2 pages.
Mm-hmm. Oh, wow.
Yeah. So, well, thank you very much. I appreciate that information.
You're welcome.
Bye.
Bye.
Okay. Do we have any more? We have so many people, I can't see them all. So, do you see anybody, Alan? Somebody waving their hand? No. Okay.
I don't see anyone.
Well, then I think we probably can conclude this. Really, you've just been fantastic as usual. You were fantastic many years ago, but you did introduce some new medications of concern, like the ones that some doctors use for treating COVID, so hydroxychloroquine and ivermectin, that type of thing. So that was really interesting to learn about that.
Yeah.
Okay. Yeah, you really added some new things. Okay, so I'm going to say thank you very much.
Thank you, Tony. You're welcome.
Appreciate what a wonderful job you did.
Thanks, Tony.
Right
Okay, I'll
before I
send you all
close-
that info that I promised.
Wonderful. Thank you. Thank you.
You guys have a great day.
Days before I can actually, I have to download the recording, and then I have to add some files to it and maybe crop it a little bit, and then I have to upload it to YouTube, and this, it just takes some time. I do want to say that our next meeting is going to be March, the second Tuesday in March, and it's going to be the 8th, and that's going to be, Caption Call is coming. and come to talk to you about some new projects they're working on, new services. They are our sponsor, and so we do like for them to come and talk to us. After that, in April, Paul Sanchez from the Speech Pathology, Audiology, and Hearing Aid Dispensers Board. It's a division of Consumer Affairs. It's been quite a while since he's talked to our people, so he is going to talk to us about knowing whether the professional you're going to is licensed, what to do if you have a complaint, issues with warranties, California regulations that you should be aware of, and he'll be available to answer any questions you have. So that's going to be in April, and it's going to be April the 12th, second Tuesday of the month, 11 o'clock, April the 12th. And so you might want to jot that down. You might actually want to put in the second Tuesday of every month at 11 o'clock. That's when we have our meetings, and so that you can check it out and see what the topic is if you're interested, and you don't schedule something you could otherwise schedule at another time. So, okay. Thank you very much for attending, and hope to see you next month. Thank you, Dr. Doherty. Bye.
You're welcome. Thank you. Bye-bye.